Well, Dr. Gay presented an update from what I thought was one of the most important presentations in the transplant space at ASH last December. And what she first showed at ASH was that in a remarkably forward-thinking study, the Italian group looked at KCD with transplant, KRD with transplant, and KRD alone with transplant kept in reserve. What she showed at ASH was that the KCD plus transplant group fared the least well for quality of response and MRD negativity. Intriguingly, the KRD group plus transplant did as well as the KRD alone group, and the MRD rates were essentially the same. And this was really quite remarkable because I think many of us, and myself included, were expecting the MRD rate to be significantly higher for the transplant group, and we didn't see that. So this suggested that KRD times 12 was as good as KRD plus 8 plus transplant. What she's presented today, I think, was a very thoughtful analysis. The data are not yet mature enough to comment on progression-free survival advantage, but what they are mature enough to show is the early relapse group. And if you look at the early relapse group, the high-risk patients appeared to have a higher rate of relapse if they didn't have the transplant. Now, the numbers are small, and that I think is a critical takeaway point for our listeners. But I think at the same time, what is really interesting is that in the clinical trial, maintenance was also randomized. And so patients received lenalidomide or carfilzomib and lenalidomide as part of maintenance. And that, of course, will have absolutely impacted on this relapse pattern. And that data we don't have yet. So I think we have to be careful, but what we can say is that for standard risk patients, clearly KRD 12 versus KRD 8 plus transplant, there was absolutely no difference even in this early relapse setting. For high risk patients, ISS 2s and 3s, there's a signal that if you don't achieve MRD negativity and or even if you are MRD negative, transplant may convey some form of advantage. Until we know more, and in particular what we know about maintenance, we'll have to see. And what really sort of changed my view of the whole transplant space today was to really digest the antibody data. And they had this fantastic presentation from Philippe Moreau about the role of daratumumab combined with VTD in transplant. And clearly daratumumab is changing or moving the needle in transplant for the three-drug platform. So the obvious next step, Don, is if we've got KRD plus DARA or we've got RVD plus DARA, where will that take us? And my sense is the power of the antibodies will once again require us to reevaluate the place of transplant. Because at the end of the day, if you can get, say, RVD DARA or KRD DARA, MRD rates 50, 60, 70% perhaps, plus maintenance, what then does transplant add? And in a subset of patients, according to Francesca's data, it may add something. But with antibodies and augmented maintenance with the use of a proteasome inhibitor, who knows? So lots more to learn, but I thought what was so important about her presentation is it showed that in transplant, one size does not fit all, and that you have to tailor the approach to the patient. And I think that message was very clear.